reports on behalf of Kuma, my co-chair of this seminar series and the Fields Institute director. On behalf of the Fields Institute and this National Task Force, I would like to thank everybody for joining us. For this anticipated to be very exciting talk from the real expert, Colijn. I don't think Colijn needs any introduction. She's a spokesperson and the real representative of the mathematical epidemiology in this pandemic in Canada and globally. And Colijn has a very good connection to all major universities, including York. So I'm very happy to notice that. And she is one of the 150 Canada research chairs recruited back to the country. And she's now a professor at some Fraser University. So thank you, Colijn, for joining us and for many of your achievements. And the rest is your time.
Okay, thank you. I hope I'm leaving time for discussion, and apologies, I have given some of this content recently in the PHAC technical modeling group, more focused on vaccination, but there's some new stuff in here for those of you who were there. Okay, so I'm going to talk about modeling and policy in the pandemic, and I wanted to highlight Elisha, who is here, Sean Anderson, Paul Tupper, Maddie Yerlinoff, and Nicola Mulberry, all now based at SFU, except for Sean, who is Department of Fisheries and Oceans. Sean developed this R package that fits a model that I developed earlier in the pandemic to data, so that's these kinds of plots that you've seen are built with his package and often built by Elisha, who is here. Okay, so I wanted to go back to a year ago, almost a year ago today. This was published on March 20th and updated exactly a year ago today, March 23rd. You probably remember the flattening the curve idea that went around that was early on and kind of started this off. So we had an article in the Globe and Mail, which is based on a model that I'm about to tell you about, that just has very simple by the standards of epidemic models, pretty simple structure around social distancing. And this was the kind of classic SEIR curve that you infectious disease modelers are all very familiar with. And I had seen the Imperial College London report, the one that was based on 9 million lines of undocumented C code, with this agent-based model with a lot of complexity around households and schools and demographics and ages and towns and buses and trains and you name it, and that's nice. But I sort of saw those curves, they go up, they go down, and I thought, you know what, I bet a simple model of distancing would look just like that. So I made one. It caught Ivan's attention, Ivan Semenuk at the Globe, and we wrote together a kind of expose around just what modeling looks like for this pandemic if we don't do anything. If we hadn't done anything a year ago, then this pandemic would be largely over. We would have had a first wave, a true wave, and it would have receded. And what we had called strong intervention, I just wanted to start this talk by contextualizing that, because one of the things that I've learned about policy, the policy link and mathematical modeling, is how important it is to put your model in a context that relates it to something someone knows. Okay, so let's contextualize this thing. So our strong intervention that had distancing going on for many months before the COVID-19 pandemic receded due to buildup of immunity, and therefore lockdowns and so on would not be required anymore, that peaked at about 8 or 7% of the population having a prevalent COVID-19 infection, of having the virus at the same time. So let's just figure out what that would be in BC. That would be about 400,000 prevalent infections, which would be an incidence of about 40 to 60,000 daily cases. In Ontario, that would look like 120 to 180,000 daily cases. Now let's imagine you only detect half of those, so that's 60 to 90,000 cases. And compare that to what we've actually done in Ontario. I don't know if Ontario is on the previous plot. Here it is. That only goes to last June. But, when we get to about 500 or 1,000, or later in Ontario to about 3,000 daily cases, we notice that our hospitals are getting full and panic and initiate stay-at-home orders and curfews in Quebec and shutdowns. We did not flatten the curve according to that idea that was going around a year ago. We prevented these curves. In fact, if we took the mouse and we traced out what we actually did, we had a tiny bump that went up somewhere down here, and we sort of fluttered around down here. We never had anywhere near even 5% of the population infectious at the same time. We have less than 5% of Canadians having had COVID today in total. So this has been kind of all the way down here. Okay, contextualizing. It's important because it affects a lot about how we interpret our models and the relevant regime for modeling. Okay, here's our social distancing model, the one that was behind the Globe and Mail and some other publications since then. Okay, so it has a simple kind of susceptible, exposed, infectious, recovered, and there's a quarantine bit here. It doesn't matter dynamically. Structure. People progress from susceptible, exposed and not infectious yet, exposed and infectious, but they don't know it yet, symptomatic, and so on. And it has one type of population structure, and that's this. These people in the D compartments are distancing. They are willing and able to participate in social distancing, so they are not high contact, high risk essential workers. They are people like me who sit at home with their laptops, and that's, many of us, and we also don't go to nightclubs and parties, and there are lots of things that are closed and so on. So this is a kind of distancing population. And the mathematical structure has this fraction F, that is the reduction in the contact rate among those people who are distancing. So F occurs in the force of infection here, reducing the transmission to people who are distancing in the susceptible distancing class. But it also reduces transmission from those people. And that's in the second bullet point, so that they are less likely to go out and contact others. So they get a reduced transmission rate to them. And when they go out, they're less likely to see other distancers, and everyone is less likely to see distancers when they go out because they're less likely to go out. So they also have a reduced transmission rate from them. And their contact patterns, this F, we allow to change as policy and behavior changes. So this is F is kind of a driver of the strength of social distancing. People can enter and leave the social distancing class at constant rates, distancing D and relaxing distancing R. And you can work out, since all these rates are constant, the fraction of the population that is distancing is just a ratio of the distancing rate divided by the total rate. The dynamics don't depend on the rate, they depend on that ratio. Okay. Maddie Hirlanoff, a student in my group, did some nice analysis in SAGE. He went and learned the next generation method and figured out the analytical R naught. And I put this here because I know that this is the kind of plot mathematical modelers typically would make. It's the kind of thing you would do. You'd make a kind of bifurcation plot, and then for contextualizing, you would make a point on the picture. And this is the point we got for BC last time, around this time last year. It was just at the end of March we started doing this and fitting this to BC data. So we had a lot of leeway. We wrote a paper about leeway. How far are you from the line? How much more could you relax, either by reducing the fraction of people who are distancing to go this way on the plot. And sorry, this goes backwards. So I guess you could think of that going up, the fraction not distancing, the fraction distancing 0 to 1. Or you could relax your measures and have the same people, but allow them, the same number of people doing the distancing, but allow them to have more contact. That would put you this way, and either way you get across the critical threshold. So that's nice to do some analysis, but it doesn't help in the sense of kind of being contextualized with data, and you could watch how this plot goes around, but it's not too informative. And we wanted to do something that would allow us to kind of illustrate where cases were going and forecast in the context of what we knew about testing and what we knew about the fitting to the case counts. So we developed a way to link our model to testing data using a few different tools. So one is, of course, we don't have perfect ascertainment. And a year ago, I was very frustrated by this, and I went through the 5 stages and got to acceptance. I'm less frustrated now. But of course, we have not ever really consistently been testing a population sample. So we don't really have measurements that indicate anything about the prevalence of the virus, but they indicate sort of relative changes if the pool of people being tested isn't changing. But then of course it did. Okay, there's also a delay between the moment of infection and the moment of testing. And there's some randomness in who seeks testing and what the testing capacity is and how fast the lab process the test. So what we did was used a negative binomial model to say, okay, here's the model incidence. That's going to give us a delayed and integrated over a distribution of delays. That's going to give us a mean. And then around that mean, we'll take a negative binomial distribution with some dispersion parameter to model how the case counts that we see actually are impacted by the underlying true dynamics. So then we put this into a Bayesian framework in R-stan. And we estimate also the effective reproduction number, or it's kind of like a basic one. The fraction of people who are distancing, we can estimate. The sampling fraction, we can sort of estimate, and more. But there are, of course, some trade-offs. And what we found, I won't go through it in detail because I want to talk about vaccination, but we did find that the distancing impact, the F, is robust. And the F comes out in these plots. This is how it's been used in practice. And you can see this is one of the ones I like because Bonnie Henry is in it and our model is behind it. This is pretty great. But this F that we estimate in the Bayesian way kind of comes out as, how much of the regular contact rate is happening among the majority of the population that are able and willing to participate in distancing. That's F, and that's the main target of inference. And that's the one that we found was robust to different assumptions about the initial numbers and the sampling fraction and the blah, blah. It's all in the long and unwieldy supplement of our paper now out in PLOS Computational Biology. But this is used in practice to kind of showcase the case trajectories, but also the imagined case trajectories if we were to increase contact or decrease contact. And guess what? Like any other epidemic model, it has a threshold. If you increase contact above the threshold, you grow. And if you decrease below the threshold, you decline, and that's great. But it allows us to make these kind of contextualized pictures that show the data. At this point here was a jump in testing. They widened the testing rule to allow anyone with symptoms to be tested. That was early on, about a year ago, and so on. Okay, so there's the model, Bonnie Henry. That was great. It's been used at the national level, and Elisha has taken this on making these weekly forecasts for PHAC, and now we're a year later, and you can kind of see we've had these little bumps a year ago. Here's BC. That was the previous plot was all over there back when we were first doing this, and then of course we had a bigger rise in the fall. And now it's looking like it's ticking up again. And these occasionally get rolled up into Teresa Tam's slides. And in particular, some weeks ago, it was used to kind of motivate this crossroads language. These models have a threshold. You're always at a crossroad of some kind. I mean, of course, you can cross the threshold or not. But that week, it caught people's attention with whether we would get to 20,000 reported cases in Canada. So that's a national level forecast that we don't fit the model to national data. We roll these up into national forecasts. Okay, so now what? Now we are essentially here. So we're a little later, we're 3 weeks later, and I've probably got one of these later. But we have two things that are changing, and I want to talk about both of them. And so, one is that variants are arriving and have arrived, and in fact have arrived in force. And the other is, happily, that vaccination is beginning. So this throws a bit of a wrench into our forecasting, but it's also, that's not really why it's interesting. It's interesting because it's interesting and important. So I want to talk a little bit about how we're doing modeling for both of these and what we're finding. Okay, so first, variants arrive in force. Higher transmission variants have now arrived in Canada and have spread across Canada and established themselves, particularly in Alberta, BC, Ontario, and Quebec, less so in other provinces. And the problem with B117, as it says here, is that we have really strong indications from the UK that it has a higher transmission rate. So it is able, by some means, maybe it's smaller droplets or aerosols or better adhesion to host cells or something, to transmit more of your contacts. If these variants are not contained, which they haven't been, the current measures, like we had in BC with cases kind of flat, will not leave our effective reproduction number near 1 anymore. It will be higher. Eric Voltz looked at data from across the UK where they had, because of the PCR test they were using, they could tell what portion of their cases every day were B117 variant cases. And he estimated about a 40 to 80% increase in the transmission over the course of infection. So a daily, maybe 8% increase. Other estimates, I think, are sort of 1.2 to 1.8, even wider than this, but anyway, bigger. And there's recent data too that B117 also looks like it's more severe. So I would say higher transmission is a bigger problem than more severe, but people also, of course, care about severity. We could be, doing more severe shutdowns and more closures. We are moving towards early detection of variants using PCR and using whole genome sequencing. We might be prioritizing variants for contact tracing, but that only works if we detect them right away. Contact tracing is just once somebody's symptomatic, you've missed so much of their infectious period and their contact's infectious periods that it's limited. And of course, you can't double your contact tracing capacity every week, but you can double your B117 numbers every week, so that's an issue. Okay, we could be doing rapid antigen tests to screen everybody with high contact once or twice a week. We could be doing that. We could be doing wide screening and testing of not just around variants or specifically around variants, everyone who's contacting or could have contacted. We could be jumping up and down at borders, and we are a little bit, but basically we haven't been doing these things. And as a consequence, B117 has established, and I think we're going to pay a steep price. All right, so we've done a bit of modeling around this. We actually have a multi-strain model too, but it wasn't used to make the pictures that I'm going to show you. So in the interim, when we just wanted, like emergency by tomorrow, we cannot send pictures to policymakers that don't account for the higher transmission rate that B117 is going to give us, because we'll end up sending pictures to policymakers that are too optimistic. So we wanted to not do that. So what we did was we took 2 copies of our familiar social distancing model, fit the first one to data on the non-variant, regular, bog standard, normal default COVID with our regular package that Sean wrote, and that's great. And then we have all these posterior estimates, right? So we have our posterior collection of F values, this contact among the distancers, and we have a number of other posterior quantities from this model, and we can just lift all of those into a new model that says, all right, then how is your VOC going to do with its higher transmission rate given that estimated information? And given the fact that the VOC's transmission rate is higher by some factor, and we don't know the factor. So we sample uncertainty in the factor by which B117 is more transmissible, and we sample uncertainty in all the stuff we normally have that goes into the blue ribbons on our favorite curves. And this is what happens. Here's the forecasts. I've got Ontario on the top, and I'm going to move your pictures away. Well, no, I'll just leave your little pictures. There they are. Okay. So here's Ontario on the top, and unfortunately this line actually goes so high that you can't even see the whole epidemic to date. And we've just compared kind of forecast projecting onward from the current state as if nothing changes versus something we've called being more proactive. And the more proactive is kind of 2 different 10% reductions, one specific to the variant and one done overall with stricter lockdowns, although no one's really doing this. So I mean, the stricter lockdowns I think are not popular and they're not happening. So you can see it best for Quebec because it didn't quite fly so high. You see here that the added uncertainty of the rate means that the ribbons get wider at the time that we start adding the variant of concern. And even with more proactive, the total cases go down for a little bit because B117 is not the driving variant. It's not the major variant yet at the time of this analysis in Quebec. It was modeled as about 20%. But then, of course, its growth takes off. So these 10% are not enough to get you below the threshold, but they get you a bit of delay in the race between variants and vaccination. This does not yet have the impact of vaccination. And then here are the ones for the other 3 provinces. We don't see a lot of variant cases in Saskatchewan and Manitoba. So Saskatchewan has a really wide error bar. They have low numbers overall. And Manitoba had very little, but Alberta and BC are facing rises, and Ontario and Quebec are facing likely rises driven by the B117 variant. These models are pretty simple. They're really not, it's these copies of these two things. There's a lot of limitations, but they have actually, I think, because they are contextualized with reference to the measures that we've had in place, I think they've had some impact, and we've had a lot of media interest in them. Although I find it a bit funny because a year on, people really should know what exponential growth curves look like. We've all seen so many of them. And yet somehow, you have something that the rate is constant and people think, nothing to worry about. Oh, I don't know what's going on. Oh my God, exponential growth. And Jens van Bergman has a great cartoon about this on Twitter, if you've seen it. Okay, so I don't know why this got quite so much attention, but I guess I do, in the sense that, it's like having two pandemics, the regular one, the blue one, and then there's this new red one, and it's news, and okay, it's bad. I think the ship has kind of sailed, and I was very hopeful that we would prevent establishment here, but we didn't, and I think it's done. Okay, so what can we do about it? This is the transition slide that is going to bring me into vaccination and what vaccination might be able to do, because of course we are doing that, and vaccination is great. So what's going to happen with vaccination? So, all right, one of the things we've learned is that from data in other places is that vaccines probably do block transmission of COVID-19. They can do that in two ways. They can prevent you from getting infected in the first place. And if they do that, you can't infect your friends and your contacts. If you do get vaccinated and then you are unlucky enough to get infected anyway, vaccines can also reduce the viral load among that smaller group of people who got vaccinated and got infected anyway. So here's a collection of 5 papers and reports that go through this for different combinations of vaccines. This is AstraZeneca, this is the Pfizer vaccine. And I think there's growing data from these sources and elsewhere that both of these effects happen. It can block transmission by blocking infection and by reducing viral load if you are unfortunate enough to be infected anyway after vaccination. So that's great news, because the driver behind our sort of age-based, risk-based rollouts has been, we don't know if vaccines block transmission. And if they don't, then we should just use them to block bad effects like hospitalization and death in the people who are most at risk. If they do block transmission, that opens up the option to try to prevent exposure in the first place. Okay, we got interested in this because we're interested in long COVID and chronic outcomes. COVID-19 can have symptoms lasting much longer than 28 days, including many months. I actually have a close friend in London who has not been able to leave the house since June because of severe kind of chronic fatigue kicked off by COVID. It was also observed in SARS, but many fewer people had the first SARS. But beyond this is, I think, fairly rare, but symptoms lasting longer than 28 days that can therefore disrupt employment and ability to pay the rent and income, that's not so rare. And there's more data emerging about it. There are also complications of COVID-19, things that are bad that can happen to you that are not dying or going to the hospital. People's deaths and hospitalizations are easy to count, and these long-term things are not as easy to count, and it's harder to attribute cause. But rates were higher in survivors of COVID-19 hospitalization than they were in matched controls. So this is not just, people who had COVID and then had a different problem and attributed it to COVID, whereas they might have had it anyway. These were compared to sets of matched controls by the Office of National Statistics and the WHO in the UK and the WHO. So these things are important, and we wanted to understand how vaccination, long COVID, chronic impacts, preventing transmission, and so on played together to understand what is the best vaccine rollout. And of course, you could say best for what. So we have lots of outcomes that we looked at. Okay, so this is transition to the part of the talk where I talk about vaccination. What's the best vaccine rollout? Okay, and I'm going to start with a little storyline model. This is a very simple model, there's no math in it, because I want to kind of prime you for this point. So why is protecting an essential worker ever going to be better than protecting someone who is more at risk of a severe outcome? And by protecting, I mean vaccinating here. Okay, so essential workers have to have a lot of contact. That's in fact how we define them. People who have to have high rates of contact at work. So it's not about how essential the work you do at home is, it's about the contact you have at work. So now that we know vaccines can prevent transmission, imagine that you can prevent, by vaccinating one essential worker, you prevent a whole chain of transmission. Maybe 20 cases over the next 9 months between now and the end of when we finish vaccinating. Imagine each of those has a 10% chance of infecting an elderly person who is vulnerable. Then you have protected 2 elderly people with 1 vaccination in my vignette model, my story model. If I only vaccinated 1 elderly person, I protect 1 elderly person. So in the vignette, I get 2 times the benefit for the elderly, never mind the essential worker themselves and all the people that they infected and all the long COVID and blah, blah, blah. Even if you only care about the elderly people's protection, you've actually protected double the number in this vignette with 1 vaccination than you can with 1 direct effect. So you get double the benefit from your indirect effect than you get from your direct effect. Now that's a storyline. Does that work with data? Yes, it does. Okay. So we took a model now published in Science by Kate Bubar and Jonathan Grad and Mark Lipsitch and others. It's a deterministic ODE model with age and vaccination and age-specific rates of hospitalization and death, which we estimated from data in BC, and then we estimated it again from StatsCan data to make sure we weren't releasing anything from our BC line list and it has a contact matrix of how many contacts of age group I, does it have someone in age group J, contact per week through home and school and work and other. And this is the Prem et al. Method that Vicky Ng also uses in PHAC for her agent-based model. We found some survey data from the COVID Speak survey in BC to look at how many people can't avoid high contact and high risk at work. And then we developed a contact structure that incorporated this kind of essential workers idea, this high contact, high risk workers. And then we accommodated social distancing, removing workplace contacts for the people who now work at home on their laptops, and scaling back other contact to match data. So this is the model structure. People get vaccinated. They can be vaccinated, but still able to be infected. So that's this kind of what if the vaccine doesn't block transmission layer. And then the force of infection is all the infectious folks together. Okay, so this structure is copied over, I think, 15 times. So it's the kind of sort of hideously large, high dimensional ODE model that is unsatisfying to work with as a mathematician, but yeah, okay. Force of infection has the contact matrix, a kind of relative susceptibility vector that is lower in kids because we think maybe they're lower in kids. That actually just works out, similarly to if you had them in the diagonal of the contact matrix. So it's not really identifiable between those 2 things. And then just a force of infection. Okay, that's the model. Here's some of what we found from the survey data for essential workers in BC, what portion of the age groups are not able to avoid high contact at work. The model is actually not sensitive to the sizes of these. We have a new Ontario one where these green parts are much thicker and it doesn't actually change of course, it changes the fit and everything, but it doesn't change the conclusions to the model. Okay, so here's a heat map of our contact matrix, illustrating that essential workers are having more contact than others. And people tend to contact people in their own age group. Of course, you have the parents of young children obviously contacting the younger age groups as well. Okay, so then I asked, what rollout is best? And I noted that if you say best, you might want to specify best for what, because it matters or potentially matters. So we had 2 ways of kind of wrapping up all the different outcomes. Our outcomes were infections, hospitalizations, deaths, long COVID, our chronic impacts. And we wrapped that up into quality adjusted life years and also into net monetary benefit. So quality adjusted life years that are lost. And that combines death and also quality of life lost due to disease or disability. And then net monetary benefit is the cost of the pandemic. We did not factor in the costs of the shutdowns. So, Okay, and that's the hospitalizations, chronic outcomes, and then a net monetary benefit thing for the qualities lost. This is very health economics-ish, and we worked with two health economists in Alberta, Chris McCabe and Aaron Kerwin on this part. You can love it or hate it. All right, here's our sort of validation. We did not formally fit this model. We tweaked it a little bit until the age-based incidence curves kind of looked right and the hospitalizations looked right. We didn't have to tweak much. The main tweaking was around the contact matrix, of course, as you would expect. But this is to show that it broadly illustrates or broadly captures the right balance of who got what amount of COVID in the fall in BC. And we used estimations of hospitalization duration and death estimated from the BC line list, and then with PHAC and Stats Canada data. And it's pretty good, over and underestimates a little bit, but you'd expect that, I think. We also, as I mentioned, have a similar model to Ontario where the fits look very similar. And actually the contact matrix, we didn't really have to change it. It's just changing the overall population scale and a little bit of fiddling. And that makes sense because the contact matrices are taken from Canadian demographics. Okay, so maybe this convinces you that first off, this model was published in Science by other people. Secondly, it makes some sense when compared to BC data and on incidence, deaths, and hospitalizations. So maybe we can start to use it to explore vaccine. So we vaccinate from January 1st, the first 60 days, we vaccinate those over 80. And we didn't model this explicitly, but acknowledging that also includes some Indigenous communities and healthcare workers and small numbers of others. During that time, we keep the transmission effective reproduction number in the absence of vaccination R relatively low with our distancing measures. This will all seem familiar. And then after that, around now-ish, there's a rise in transmission. And that could be because we reopen, we don't comply, we relax, or we have a high transmission variant. Actually, we're doing all of these things, I think. But then we'll shut down again, probably when our hospitals get full again. Okay, so there's a rise in transmission. And then for the next 200 days until September, we follow some vaccination strategy at the originally published mRNA vaccine rates, which worked out to about 0.5% of the population per day to get to most people after the 200 days, most people who want a vaccine. And so one thing Nicola Mulberry, was code up a really flexible, nice suite of vaccination strategies that we can use so we can bin the groups together in arbitrary orders and combinations. So you could look at kind of the standard oldest to youngest baseline, which was the current plan, probably still is the mRNA vaccine plan in BC. We could look at 80 plus, then everybody else, or 80 plus, then essential workers, then continuing the age rollout, and so on. We could do whatever arbitrary protocol we wanted. And this is the kind of thing that we find, namely, as in the little storyline vignette, vaccinating essential workers sooner actually gives you fewer infections, less long COVID, but it gives you fewer deaths and fewer hospitalizations as well. So here's an illustration of 4 different vaccine schedules, oldest first, and you see each lines correspond to age groups, as do colors. And the lines rise to the hesitancy, to 1 minus the hesitancy. So we have an 85% acceptance in the oldest groups, and then it's down to 75-ish in the younger groups. And they just get vaccinated in sequence, or you do 80 plus and then everybody else, or you do 80 plus and then essential workers here, and then the age rollout. So you see that this delays the rest of the ages only by a few weeks because it doesn't take long. It's a small portion of the population to vaccinate the essential workers early on, and so on. And then these plots illustrate what happens. So I'll zoom in. Here's incident infections. And on the top, we have oldest first versus oldest and then everybody else. And you can see that by getting the younger people sooner, you reduce infections. But you actually pay a cost a little bit in hospitalizations. There's a tiny bit more hospitalization, in particular in those in their 70s, because they had to wait longer. If you put essential workers first, instead of this, you get a much lower decrease in, you get a much lower incidence, continue the age rollout, and you don't pick up that excess hospitalization. You actually get fewer hospitalizations here than you did here when you just did oldest first. So what's happening is preventing transmission by preventing cases in essential workers has a cascading effect that actually benefits everybody. It benefits those in their 80s and 70s and everybody else because they're not exposed. Similarly for deaths, you get fewer deaths and you get, of course, much less, fewer cases of long COVID. Okay, so that's kind of the punchline. Here's one showing, instead of trajectories, showing these as bar plots where the strategies are oldest to youngest. I'll just talk about two of them, the green one and the purple one. So they're basically the same. They're the age-based rollout, except that in the purple one, we put essential workers at an earlier priority. And you can see that even if efficacy against infection is a little different, or if the R that we reopen to is a little different, or if we look at hospitalizations versus these other outcomes, it's the same picture. You get the purple bar is lower than the dark green bar, and it's noticeably lower. Here, it's not too much lower, it's still a little bit lower. That's if we kind of stay mostly shut down for the rest of the year. But if we reopen or we have a variant or whatever, we see huge differences and noticeable differences in deaths and of course in long COVID. Okay, and it's robust. We explored sensitivity to all kinds of stuff. Here's some of the stuff. The portion of the contact that happens among the non-essential workers, so how much work contact is there? The fraction of workers that we call essential high risk, high contact, double it, halve it, you get the same thing. The strategies, exactly when you put essential workers earlier, do you put them and then everyone else, or do you do the age-based rollout, or do you do them before the 70s or after the 70s or whatever? We looked at the underlying efficacy against transmission that was in the x-axis of the previous slide. The underlying transmission with R, the rate of vaccination, the type of model. You can get this in a complicated model. You can get this in an agent-based model. You can get this in a simple model. You can get this in a cartoon model, which I'm going to show you in a few minutes. And the point that vaccinating essential workers sooner is better is robust to all of this. We also looked at resampling the contact matrix. So that's where these error bars come from. So it's not exquisitely sensitive to some little bit of the contact matrix. Okay. When is it not right? So it's robust to all of this stuff. When does it break down? Well, it breaks down if everyone gets exposed. So here I've shown much higher reopening. So this is to an R in the absence of vaccination of 2. And this is like in our first slide with the Globe and Mail model. If we were willing to see 40,000 incident cases a day in BC or 120,000 in Ontario, then, because ultimately almost everyone gets exposed, then it's better to vaccinate oldest first. So here, oldest first works better for hospitalizations and deaths than a strategy with oldest and then everybody else. So this is still oldest, very oldest first, but then everyone else. But even so, when you put essential workers earlier, if you compare this to this, so this is oldest to youngest, and this is oldest to youngest with essential workers in near the beginning, you still see fewer infections. And you see slightly fewer hospitalizations, right? So this plot is lower than this one. And you see about the same number of deaths. So here is where it starts to break down for deaths. And you would start, if R got higher, you would start to see more deaths if you prioritized essential workers earlier on, because even those few weeks of delay are enough to make that difference. But if we're not willing to see 40,000 incident cases a day or 60,000 incident cases a day and just have this pandemic roll through our population, which we aren't, because we have always introduced controls when we get to a 20th or a 50th of these levels, then vaccinating essential workers will be much better in this model. So I would say it does break down, but not here. And this is why I think that Bubar et al. Paper in Science was actually really, it's a little bit irresponsible, because they strongly stated in their abstract that 60 plus first will save deaths. I think that is not the case in their model. If you take into account high contact And if you contextualize your model for your own situation, and that's the situation not just in Canada, but in the UK, they turned things around with severe lockdowns when they got to 50,000 cases a day. This would be 500,000 incident cases a day, maybe a little bit less from ascertainment. Okay. We wrapped up these outcomes into quality adjusted life years, and we found that vaccinating essential workers earlier is still better. Oh my God, these are not exciting bar plots. I think the exciting thing to look at is really how big the pale green part is. So that was the secondary point we wanted to make. And we thought it might make a difference, you know, taking chronic impacts into account and weighing them appropriately might push things in favor of vaccinating younger people because they have chronic impacts for a long time. But it doesn't really change the picture. It just adds to the loss. So, and it adds a substantial part of the loss. And you can see that the purple strategy C is still better than the oldest to youngest for all of these situations. Doesn't depend sensitively on the vaccine's efficacy against transmission or on the reproduction number that you get to. The numbers change. Of course, it doubles the cost if we have a higher transmission rate. And that also makes the other point, which I will say, I guess, here, the transmission matters a lot more than who you vaccinate first, actually. If you want to look at deaths, even in the context of vaccination, having a transmission rate that is higher gives you a lot more deaths across all of the outcomes. And that this difference between reopening to an R of 1.15 versus 1.3 actually drowns some of the differences in the vaccine rollouts. Transmission, it's a big deal. All right, for those of you who like infectious disease modeling and do it a lot, you'll have heard of herd immunity. It's a phrase that's been kind of co-opted and misused in the pandemic. In our model, we looked at how many people you would have to have vaccinated or vaccinated or naturally infected in order for the trajectory to turn around. So we called that the herd immunity point. Doesn't mean you're immune, everyone's immune in the herd. It just means here, the cases have turned around. And you can find that here again, we have the green and the purple strategy. When the R value, the reproduction number in the absence of distancing, is low, it makes a huge difference who you vaccinate first. In the oldest first model, you have to protect nearly half the people in order for the trajectory to turn around at R is 1.25. If you can vaccinate younger people sooner, you need far fewer vaccines before that happens and far fewer natural infections. Same here, how many people have to be vaccinated? Let's go down to the 1.25. You need only 5% vaccinated. Of course, a lot of people get naturally infected. That's the difference, the other 10%. At the younger sooner strategies, all of them, doesn't matter which one, these lines are all close. And then as R increases, you do get to this kind of theoretical max. The theoretical 1 minus 1 over R is the total portion that have to be either vaccinated or naturally infected. It kind of looks like that. But you see these lower R's, there's actually a big difference in the amount of infection or vaccination you need before you turn around, depending whether you can protect people with contact. So it has implications for reopening, which we're now looking at. Okay, so I'm going to go to the less formal part of the talk. I'm going to check the time. Okay, good. We have some time. Okay, so the intuition model. This is a response that we've had. So given the high fatality rate in the elderly, how is it possible that delaying their vaccination might be better? That's just not my intuition. My intuition says the risk rises so steeply with age that it must be better to go oldest first, and your model is just a model. Okay, here's my response. Intuition is itself a model, and the intuition model is making assumptions, which are not usually clearly elucidated, but here they are. The intuition model is everyone is equally likely to be exposed. So yeah, if that's true, sure, you better go oldest first. And also that people don't infect each other, that everyone's kind of at risk in some independent way. Like maybe they're not all going to be exposed, but they're all kind of, exposure is going to rain down from God. It's not going to be dependent on who's contacting whom. Of course, we know that both of those assumptions are wrong, but those assumptions are implicit in that intuition model. Intuition models or intuitive models are models too. They're just models that can't be interrogated. So we have, you know, public health people sometimes saying, oh, well, that's just a model. Well, you know what? Your intuition is just a model too. Intuition says older people are more at risk, so they must be vaccinated first. But when we take unequal exposure and transmission from one person to another into account, we get a different answer. And that is that you can prevent exposure, and that's better. So I would say it like this. Let's imagine you're 60, okay? What's better than having a vaccine in 8 weeks' time from today? I'll tell you what's better. What's better is having that vaccine in 10 weeks' time, but having only a fifth the exposure in the intervening 10 weeks. Just think about your total risk, exposure at 5 times the rate, but your vaccine is in 8 weeks, versus exposure at a fifth the rate, but vaccine is in 10 weeks, which is better for you. The 10-week one is better for you. Okay. Here's a cartoon model, and I will end with the cartoon model. So I drew these cartoons. This is my iPad simulation model where I draw pictures, and it's great. All right, so the people in gray are the essential workers, or the high contact people, and the people in blue are the vulnerable. Our only goal is to protect the vulnerable. We need to protect these blue people. We're imagining that long COVID, infection, hospitalization, nothing in these gray people matter. They're gonna be fine, all fine. Okay, so I've drawn a low transmission rate simulation into my gray people here, and the red arrows are the virus transmission. Okay, I'm gonna do 2 experiments. One, I vaccinate directly the vulnerable, and I vaccinate 5 of them. And when I vaccinate them, I paint them green. Okay, so here I can just count how many severe outcomes I've prevented. I've prevented 1 here, 1 here, and 1 here, right? Because those people would have been infected. Okay, now I'm gonna do another experiment. I'm gonna protect 5 of the gray folks, the essential workers. So I painted them green. And then I'm going to say, all right, you guys, let's imagine I have a perfect vaccine. So they prevented all this transmission. So every edge that came out of a protected gray person, I'm going to put a yellow slash on it to say that's an edge that didn't happen. So you can see that I have lots of yellow edges crossed out. And here I've protected, I haven't vaccinated this person. So this person kind of lost out, right? But I have protected 1, 2, 3, 4, 5, 6 vulnerable people. So in my iPad simulation model, I've protected, when I vaccinate the vulnerable, I directly protected 5 people, and I prevented 3 cases. In my high contact vaccination simulation, I had 5 direct protections, that's these 5, but I prevented 6 cases in the vulnerable. So I've stopped 11 cases. The 5, well, this guy, yeah, they all got infected. Did all of them? No, I protected 1 of these guys who didn't even get infected at all. He was fine. Okay, so, but it shows you that indirect effects can be bigger than direct effects. I can also show you how it changes when the transmission is high. So this is my, oh my God, it's so high that we're out of Canada. We're in some high regime where it doesn't matter. I'm going to do the same experiment. And in fact, the picture is the same, and I've just added more arrows because the transmission rate is higher. So the virus has all these opportunities. This poor sucker was exposed twice actually by these 2. So if he hadn't got infected by this one, he would have got infected by that one, and so on. So transmission is high. Here, I vaccinate the vulnerable, and I prevent 5 cases. Here, I vaccinate the high contact folks, and the situation is different. I have many fewer of my edges are crossed out with yellow, and that's because there are more paths to go around, right? So this person, by vaccinating them, I protect these 2 vulnerable individuals, and I protect them. But by vaccinating this one, I failed to protect this whole chain here because they got infected anyway. This guy got infected anyway. So I protect a few, but there's too many routes. And so what happens, if I do the tallying, is that I have 5 direct protections, but I only prevent 4 cases in the vulnerable when I vaccinate the high contact. So if transmission's really high and everyone's going to get exposed, you're back to the oldest first is best. All right, you can also show this in much simpler models. David Earn has a model from some time ago that looks at this. So we haven't done that, but you can do this in a cartoon model or a simple model or an ODE model or an agent-based model, and you will get the same qualitative result, which is when Not everyone is going to be exposed because transmission is low enough. You have these sort of long stringy chains of transmission in trees, and you can axe a lot of them, the downstream transmission, with one early protection. Okay, so contextualizing, because we are in this mode. We are not in this mode in most of the Western world. All right, the CDC in the US recommends vaccinating essential workers early, alongside people aged 75 and older. So really right in that 80 plus first, and then this right after long-term care and healthcare workers. I am delighted to say that last week on Thursday, BC announced a rollout to essential workers. This is from the Office of the Premier. This is from the CBC article. And that is going to include first responders. We actually met with some firefighters. It was pretty cool to talk about, how they might advocate, but they were included. Grocery store employees, teachers, childcare workers are going to be eligible for COVID-19 vaccination. Probably, I think they're doing the AstraZeneca vaccine here. So they're not even delaying older people. I think they're just layering on as they get extra doses. They're trying to layer them on in this way. And they asked us to do this essential workers part of the modeling, and actually the 10-year age bands they had asked for in December, and we were a bit reticent to get into it. But we did, and I think it was, there are many voices and many aspects to this, but I think our work was influential in these decisions. Okay, so conclusions. Long COVID and chronic impacts matter, and there are bad things that happen to young people and normal aged people and you and me if we get COVID. And so reducing transmission has those benefits. It's not just hospitalizations and deaths. It's great news, vaccines work. It means we can reduce transmission with vaccination. There is no huge trade-off if we prioritize essential workers. That's the 10 weeks versus 8 weeks thing. It protects everyone in our models. And there's an equity argument here. Essential workers have borne the brunt of the pandemic. They are often in low incomes. They often have low bargaining power to insist on safe workplaces. They have had COVID-19 in Toronto at 2.5 to 3 times the rate of others in neighborhoods with high numbers of essential workers. So vaccinating them is kind of like vaccinating your GP. You don't vaccinate your GP because he or she is so at risk of a severe outcome. You vaccinate your GP because they're at risk of exposure. This is an infection that transmits in communities before people know they are sick. And a lot of the transmission happens at that time, especially, now that we are so aware of COVID and we're so aware that people with symptoms should stay home. That means people driving your bus, working in your grocery store, serving you in a restaurant, if you live in BC and you are lucky enough to be able to go to a restaurant, these people are as much at risk as healthcare workers in some contexts, and there is an equity argument for vaccinating them. Okay, I want to thank Elisha, who is here, Nicola and Paul, who worked on the vaccine work with me, Aaron and Chris in Alberta, Sean Anderson from Fisheries and Oceans, who developed the COVID Seer package, and our team that works in collaboration with BC CDC. I've mentioned them, but my opinions are my own, so just to note that. Thank you.
Thank you, Caroline, for the very exciting inspiring talks, and there are a couple of questions waiting for you already. Since you mentioned David earned last name, so last time, so maybe we'll start with David. David, you want to raise a question directly?
Okay, what I said in the chat was just responding to Jonathan, actually.
Okay,
so he should probably ask that question. Since you say, I'll just say something which occurred to me. Thank you for a lovely talk as usual, Caroline. In your cartoons, it struck me that you're not showing any transmission from the vulnerable individuals to anybody else. And yep. If you were to show the transmission events, that could occur from them, it could strengthen the point, just because you're going and vaccinating them anyway, and you're not getting any benefit by the fact that you're wiping out the transmission that they could have caused to other vulnerable people. Just a thought with the cartoon.
Yeah, that was actually inspired by making a cartoon from our simple model, which you then had flagged to me that you had already done a simple model like that, so we didn't need to bother doing it. So we had kind of transmission is only happening in these high contact people. But yes, you're right. And especially in long-term care, that cartoon would completely not work, because you would have a whole group of very vulnerable people who transmit potentially a lot to each other. And then you got to vaccinate them, which is exactly right. So we've been doing that.
And anyway, I don't know if Jonathan is still here, but he should come. He's also the first author of the paper that you're referring to. So,
Sorry, Jonathan.
Yeah, it's the story of my life, being in David's shadow. So that was awesome. And like the vaccine, you're thinking about it and working on it and presenting it on so many levels. And I loved it. And I'm glad to have the chance to say so. The reason Jenna Holm called on me is that a million years ago, when you were still talking about the previous part of your work, I got a little confused. And I guess since I'm called on, I'll mention. So you have these scenarios where you're more and less proactive.
Yeah.
Can you go back to that graph quickly, or?
Yes, I can.
It's actually not, I almost didn't ask, but I guess I've passed that point. The work is just very impressive.
Yeah, so
okay, perfect.
More proactive.
So I was really surprised, and I don't know if it's something to do with the timing, but when you move from left to right, you see this huge difference in Ontario. And it looks quickly like doing the same thing in Quebec makes less of a difference to the outcome than Ontario. And I was wondering if there was something interesting hiding there.
So I will let Elisha weigh in if he has an opinion, since he made these, but I would predict that that's because Ontario was rising anyway before. And so you're already above the threshold, whereas Quebec was just below the threshold, and it's around thresholds where some small change makes a massive difference in all of these models. I don't know.
Right, so that's how I interpreted the left, but I'm wondering why then Quebec's not also lower on the right.
It is. So this is Ontario and this is Quebec. So Quebec, that 10% change brought Ontario from above the threshold to just below it in the blue curve. But in Quebec, since it was below it already, that 10% change made it way below it, and it starts going down. I don't know. Elisha, do you have more insight than me about that? I'm thinking that's probably a no.
Okay, yeah, I think that's the same explanation I'll give, apart from the fact that the scale is also different.
Yeah, no, I did notice the scale, but I figure you can just divide that out. And I was looking more, I'm disadvantaged here by being colorblind. I was looking more at the upper, less blue, possibly more red kind of curves.
Yes, the upper curves are indeed red, and thank you for pointing that out. We should make a color, a more color friendly.
Oh, it's color friendly. Like the colors are completely clear. It's just that I don't know what to call them.
Right. Okay. Upper one is reddish and the lower is blue. Yeah, I think it's that Quebec was below the threshold and Ontario was just above it before the VOC was introduced. So that's gonna be driving that change.
Thanks.
Thank you. So is that saying that that decrease by 10% to have double effect, right? So you're slowing down the replacement rate, frequency, and you also reduce the transmission of both.
Yeah. So we have a kind of measures that impact all the COVID and then variant specific measures. Jacques, did you have a question or comment?
Yes, there was a question discussed in the news last weekend. Why are these situations in Quebec and Ontario so different? And what you're in terms of predictions and forecasting, and at least from the media, teams are gloomy in Ontario and not so bad in Quebec. And the question is why? As regards the effect of the variants, for example. And so you're suggesting it's gloomy in Ontario because they're already in a bad place and Quebec is slightly better.
Yeah, I mean, I have also heard that Quebec is doing very, very well with variant data, with integrating their sequencing and clinical and epidemiological data and acting on it. And that, of course, isn't in these kind of trajectory, course level models. So they may actually be doing more, that will allow them to do more variant specific interventions. If they can detect it and integrate it with their contact tracing and their public health data, they will be in a better position to act on it. And I hope that that's what's happening.
Yeah, at least in Montreal, where most of the cases do occur, the health agency is quite aggressive in monitoring school outbreaks, and in fact, they even revised their vaccination priorities to kill those outbreaks.
Yeah, that's interesting. I think it's, it's hard to imagine a vaccine as an outbreak response tool directly, just because it does take a few weeks for immunity to build. But it's interesting that they're changing their vaccine.
Yeah, they were just afraid that it was two very identified neighborhoods in Montreal, and it seems to come from the school, so decided to vaccinate all the personnel and the parents, and so really localized intervention.
Wow. Yeah, I wish they would, as a parent, I wish they would do that here. That sounds fantastic.
So, I mean, this was, I think, the most aggressive adaptive method deployed.
Yeah, and I think if they're doing that, particularly around variants, it will strengthen the response a lot.
Okay.
Karen, I have one last question, because I think people are leaving because there is another technical presentation at PHAC. Now, what's the definition of essential work? Is that in terms of models, the number of contacts, or?
Yeah, it was just people who cannot avoid having high levels of contact at work. Okay. So we weren't too precise about it.
Great. Again, thank you very much, Colijn, on behalf of the Fields Institute and Kumar. And really thank you for you coming to talk. I know you also spoke to Ontario Science Table as well. So it's a very good example that model is indeed have influence. I hope keep all the good things happening.
All right, thank you. Thanks for having me. And thanks for coming, you guys, especially those who've heard some of this before.